Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of psoriasis. Dr. Travis Brown, would you mind just turning to the side?
Mm-hmm.
Is that a rash?
I hope not. You never know. Yes, we are talking about psoriasis and rash. Rashes being what the category it falls into. But I've got to mention that rashes are a really difficult area for doctors. For me personally, going through the amount of causes for rashes that you can pick up a skin textbook, and they are there's hundreds of them, and ways to approach rashes and is it history.
Is it such that you could have almost the same photo of a very similar rash, but it has different causes? Or
look, there is so many different ways of looking at this, and even when you look at the history of rashes, our ancestors didn't know much about these. Even when we look at psoriasis, they were unable to distinguish until a few hundred years ago the difference between leprosy, like rash, and psoriasis. They confused the two, and this was notable in the writings. And actually, the person we call the father of dermatology was a person who was able to distinguish between leprosy and psoriasis. His name's Robert Willan, and he was an English physician at the end of the 18th century, the start of the 19th century. Now, he's an inspirational character, mainly because he was a doctor who worked in for people who actually couldn't afford to get medical care, and he dedicated his life to treating these people. And part of that, he worked in London. He worked 20 years in the Carey Street dispensary, and he ended up looking at skin disease, skin conditions. He ended up writing a volume of it's called On Cutaneous Disease, Volume 1, where he would actually separate rashes, and he put them into 8 different categories. There was a macular, papular, xanthomata, bullae, pustular, vesicular, tubular, and squame. And when you start to actually dig down to that, that's an incredible achievement. And again, this was something, when I was a doctor, you're okay, we've got a rash, it's red, is it macular, papular? And that's where I capped out of the knowledge.
And wouldn't that be a lovely little range of gift greeting cards for medical students?
Yeah, and look, it is just a challenge dealing with rashes, and that's why we have a whole specialty, dermatology, that is dedicated. Now, Robert intended to write a second volume, but he ended up dying because he looked at caring for a patient, and he developed hemoptysis and died. And so, look, what we know about this today, so psoriasis, we know it's an autoimmune disease. It's a chronic inflammatory skin condition that causes these scaly plaques. It can be itchy. We have 4 classifications as well as special sites, so it can affect the nails, the palms, the feet. And look, it's the really amazing thing about it this day is we can actually treat it, and we can treat it very well. And so sufferers who have psoriasis can actually get it essentially resolved.
Typically creams or
there'll be medications and everything. So look, this is why we've pulled together some experts to discuss and really, I guess, help people who have psoriasis to really get the help that they need.
And it's one of those fields where you can't make a rash diagnosis. Associate Professor Laura Scardamalia is a consultant dermatologist, a fellow of the Australasian College of Dermatology, and clinical associate professor at the University of Melbourne. She's head of dermatology at Western Health, the head of paediatric dermatology at Sunshine Hospital, the clinical leader of dermatology and head of immunobullous and vascular anomalies clinics at the Royal Melbourne Hospital, and consultant dermatologist at the Royal Children's Hospital in the dermatology department. She's also senior lecturer at the University of Melbourne, involved in clinical research, supervisor of training and clinical supervisor for the Australasian College of Dermatologists, national examiner, and awarded the Presidential Citation in 2018 and Certificate of Meritorious Service in 2024. Laura is our guest here on This Medical Life podcast. Laura, welcome.
Thanks so much, Steve and Travis. It's my pleasure to be here.
Let's start with the common presentations of a patient with psoriasis. What might they be?
So probably the most common we see is the chronic plaque psoriasis, which accounts for roughly 85 to 90% of cases. And these patients typically present with very well demarcated erythematous or salmon pink plaques with overlying silvery white scale, and they're usually in a symmetrical distribution. And these typical sites are the extensor surfaces, such as the elbows and knees, as well as the scalp, trunk, lumbosacral region, the umbilicus, and the natal cleft. And the scalp involvement is also another very common presentation. It's reported in about 75 to 90% of patients over the course of disease. And these patients typically have quite a lot of scale, sometimes in a separate defined plaque, but other times quite generalized, and it can be itchy, painful, and also embarrassing. Some people notice more hair shedding, with their scalp psoriasis being active too. The other common presentation is actually genital psoriasis, and this is reported in up to about 60% of patients over a lifetime. And in fact, also flexural, or otherwise known as inverse or intertriginous disease, is quite common and often under-recognised. And this often coexists with the genital and chronic plaque psoriasis too. And this is often red to pink with little or no scale and doesn't actually spare the creases. And it's often misdiagnosed as sometimes a sexually transmitted disease or other inflammatory diseases or infections. The other common presentation is nail psoriasis, and this affects up to 50% of patients at any given time and reported to be up to 80 to 90% of patients over a lifetime. Sometimes it's the only visible manifestation of psoriasis. And the useful nail signs to recognise in these patients is pitting, but sometimes onycholysis too, and this is very common. Guttate psoriasis is what you will often see in the younger population, especially children. And this is the one that so often comes up after a streptococcal throat infection. Then there's sort of rarer forms like pustular psoriasis, generalised pustular psoriasis and erythroderma, but we don't see these as commonly. And the symptoms that patients typically present with, other than the visible appearance, is that they might be itchy. Their patches might be burning. Sometimes there's soreness and pain. There might be fissuring, bleeding and scale. But actually some other patients, other than the visibility of the skin, have surprisingly little physical discomfort, despite the disease sometimes being quite widespread.
Is it possible that a patient pops in to see a GP for something else because we acclimatise ourselves to things and the GP says, hang on a minute, I want to ask you some questions about this? Would that be common, or would there actually be a patient would definitely be presenting if they had something like this?
I think psoriasis is actually a lot more common than sometimes people realise, and some people or patients will think that it's a trivial condition or not important compared to other diseases out there, but so often it's really hugely impactful on their psyche and self-esteem. So I think it's good to look out for it and maybe mention it if you're seeing a sign.
What is psoriasis?
Yes.
Yeah, so in a nutshell, psoriasis is a chronic immune-mediated inflammatory disease with both cutaneous and systemic manifestations. So we now know that it's not simply an epidermal overgrowth disorder. Instead, it is an immune-driven disease with both the innate and adaptive pathways that these then trigger a keratinocyte amplification loop. So clinically, we now best view it as the disorder of immune dysregulation, epidermal hyperproliferation, altered keratinocyte differentiation, altered angiogenesis, and chronic tissue inflammation. So a genetically susceptible host is exposed to environmental triggers such as trauma, streptococcal throat infection or other infections, inflammation, sometimes from smoking or obesity or stress, and certain medications. And this then triggers an immune response, and the T helper 1 cell pathway with the T helper 17, tumor necrosis factor alpha, interleukin 23, interleukin 17, 12, and 22 being involved, just to name a few. And these immune cells then impact directly on keratinocytes in the epidermis, and these then expand superficial blood vessels in the dermis, and it causes thickening of the skin and thinning of the suprapapillary dermis, which gives the very red appearance of the plaques and also explains the scaliness too. And there's often inflammatory cells like neutrophils recruited. And then there's a positive feedback loop of inflammation, and this drives the characteristic reduction in the epidermal turnover time seen in psoriasis, which in a normal skin is 28 days and in psoriasis becomes 3 to 5 days.
So you mentioned that there's a systemic component to this. Do they have risks of other diseases because of that? Or is there actually a component underlying, sort of like they have increased inflammation in other tissues or other organs?
Yeah, so more and more we're recognising that it's a systemic inflammatory disorder. And we are really emphasising this, that there are associations with cardiometabolic health disease too. Insulin resistance and just chronic MACE issues as well, with especially more inflamed skin.
Now, how common is psoriasis in the general community?
Yeah, so it's reported to have a global prevalence of about 2 to 3%, and thus affecting about 125 million people worldwide. But maybe newer modelling is suggesting that the estimates have been a bit low and it's more close to 4 or 5%. And actually, the global psoriasis burden has been increasing over the past 30 years, showing a doubling of diagnoses, and this is particularly in countries with higher socioeconomic regions. In Australia, a recent publication in an Australian journal suggested a physician-diagnosed prevalence of about 2 to 3%. And so this does make psoriasis one of the commonest inflammatory disorders that we're seeing in practice. And it's probably more common than this, I think, because I think there's a lot of people walking around with forms of psoriasis that they're not aware of. Many scaly scalps that are thought to be dandruff are often actually psoriasis. And many people aren't aware that they're thickened, scaly, cracked patches of skin on their elbows, knees, their palms and soles are psoriasis too, and that they can do something about it. And psoriasis can begin at any age, including childhood, but the classic onset peaks are usually in the late adolescence, early adulthood age of 15 to 25, and then later on in life, particularly in the 50s and 60s. And men and women are both equally affected, with most cohorts showing the same sort of distribution over both sexes.
Is there any racial or geographical distribution of psoriasis?
Yeah, but I think we need to interpret the reports with caution because, biology, healthcare and access, as well as under-recognition, probably all influence the reported prevalence. And, the reported prevalence is absolutely higher in high-income countries and in older populations. And psoriasis globally is often less frequently reported in non-Caucasian populations than in Caucasian ones. And I think this may also reflect a mixture of both genuine variation but also underdiagnosis too. So, in Northern Europe, the prevalence in the highest sort of Scandinavian parts of Europe is thought to be 8 to 11%, whereas in Western Europe, it's similar to Australia, 2 to 3 or 4%. And then in East Asia, it's less than 0.2%. So I was looking for some published data for First Nations peoples, and it's very limited. And in the past, we were sort of always taught that it didn't happen in First Nations people, but we think this is probably not the case. And the lower reported prevalence might sort of reflect both, epidemiological differences, but under recognition, and possibly also to do with healthcare access. And also in skin of colour, psoriasis lesions can sometimes be misdiagnosed because they're often, they're not red. They might be more violaceous or dusky or actually hyperpigmented. And the post-inflammatory process can lead to either extra pigment or actually hypo or depigmentation. And this can be quite a significant burden too.
So what are the risk factors for developing psoriasis?
Yeah, so we see the risks are very much the interaction between your inherent genetic susceptibility and environmental triggers. So typically the important risk factors and flare triggers are if you've got a family history of psoriasis, obesity, smoking, alcohol excess, psychological stress, skin trauma, and certain medications. So with respect to family history, if one parent is affected, there's a 10 to 20% chance the child will have psoriasis. And if both, goes up to 40 to 60%. And actually in identical twins, there's about 35 to 70% concordance. So it does show you that environmental factors are also important alongside the genetic ones. And so those with no family history, the baseline population risk is about 2 to 3%. And those lifestyle factors that I touched upon, especially poor diet, insulin resistance, diabetes, smoking, and obesity, have clinically important associations with psoriasis, and especially severe psoriasis. And obesity can worsen the severity and also reduce response to therapy. So adipose tissue is actually considered a pro-inflammatory organ, which actually produces the immune activation of T helper 17 and thus activates the interleukin 17 pathway, which is the critical pathway of psoriasis. And studies have actually shown that improving diet and shedding excess weight can improve the severity of psoriasis in many patients and also improve the effectiveness of some of the treatments. But rather than focusing solely on weight, we actually really try and aim for decreasing central adiposity. And I think this is a very helpful guide, and it does encourage patients to aim for a decreased waist circumference rather than focusing on weight loss. And also, trying to decrease high glycemic and ultra-processed foods, improving insulin resistance. These can really make a significant difference to the psoriasis severity and sometimes actually completely minimise the treatment needed. And as we sort of touched on before, those major adverse cardiovascular events, or MACE, are definitely increased with those with moderate to severe psoriasis. And the mechanism is thought to be due to chronic systemic inflammation linked to psoriasis, which impacts actually on atherogenesis and atherosclerosis. And so smoking is also associated with psoriasis and seems to cause at least a twofold risk in the increase. And it's also particularly associated with palmoplantar psoriasis. Streptococcal infection is especially relevant in guttate psoriasis and can precipitate sudden widespread eruptions in children, adolescents, and young adults. Other viral infections, including hepatitis C, HIV, COVID-19, influenza, and numerous others, can exacerbate or flare psoriasis too. And then Candida often coexists with psoriasis in the folds, and Malassezia yeasts exist with scalp psoriasis in the scalp and over the seborrheic distribution, and these can contribute to psoriasis, particularly over the face and scalp. And alcohol excess also increases the risk for psoriasis and may exacerbate the severity, probably via inflammation. And some medications too, and it's important to actually check if your patients are on this and their psoriasis is triggered, especially lithium, but also beta blockers such as propranolol, antimalarials such as hydroxychloroquine, interferons, especially interferon alpha, some non-steroidal anti-inflammatories. Paradoxically, TNF alphas can sometimes cause psoriasis, especially palmoplantar pustulosis, and especially the withdrawal of corticosteroids. And in fact, oral corticosteroids are not appropriate treatment at all for psoriasis in general.
I'm just reflecting on those risk factors, especially the ones over which we have some control.
Yes.
Laura, does it surprise you that you are yet another guest on This Medical Life who seems to be advocating for giving up smoking, moderating drinking, eating whole foods and looking after yourself?
I know it's so boring, isn't it? But sometimes I try and say to my patients and actually to myself to treat myself like I actually, am a goddess, not a garbage bin, and to love myself like I love my children and my loved ones and to treat myself accordingly. And because it actually does make a difference to systemic inflammation. And we know psoriasis is actually all involved in that, as are so many skin diseases.
Goddess, not a garbage bin. There's a T-shirt slogan for you.
Now you've mentioned genetics is a strong component of all this. Is there any gene testing or genetics that is useful in these instances?
No. Routine genetic testing is not used to diagnose ordinary plaque psoriasis in day-to-day clinical practice, and psoriasis is actually considered a polygenic, multifactorial disease with no single useful gene association. I mean, there are lots reported and some in some studies, and there's definitely research in these areas, but none of them to date have been proven useful.
Now, you've mentioned a number of subclassifications, so guttate, pustular, chronic, erythrodermic. How useful are these subclassifications? What do they mean, really?
Yeah, well, I think they're absolutely useful because they do influence urgency, the likely triggers, the workup needed, and then helping to choose appropriate treatment pathways. So with chronic plaque psoriasis, which we discussed before, this is the majority of cases, and it's the major one that we will see in our consults. It's that typical symmetrical extensor surface, beefy red to salmon pink thickened scaly plaques with the silvery scale. Most people recognise this. It does, however, vary in extent, in severity, in thickness, in the symptoms, and it might be stable or then suddenly have an unstable active flare. Guttate psoriasis, we mentioned, is more common in paediatric patients. In about 2 to 10% of cases, we see this. And this is when you get this sort of sudden eruption of many small drops or raindrop-like papules and plaques. And it's typically, the classic reports are following a streptococcal infection, but any infection really can trigger this. It's very unusual to see this in older adults, and this one actually often just self-resolves, but it does tend to recur. It doesn't often need as much long-standing treatment as some of the other types, but actually it can then transform into chronic plaque psoriasis down the track. Pustular psoriasis is uncommon, and it's generally in less than 5% of psoriasis, but it actually is clinically important because it might be quite severe and also it can become systemic. It's most commonly seen in the palms and soles, has got that strong association with smoking in some, and it can be a lot harder to treat, more recalcitrant than the non-pustular forms. And then the erythrodermic psoriasis is rare. It only occurs in about 1 to 2% of psoriasis, but it's a very high-risk form, just like all types of erythroderma, which is when there's almost complete body surface area of erythema. And it's a high-risk form because of exacerbation of fluid loss, protein loss, temperature dysregulation, infection risk, and systemic metabolic instability. These patients need to be admitted acutely and managed in hospital with dermatological and medical care. They're actually really unwell. And then there's those other additional phenotypes, and it helps to know about them: the scalp psoriasis, the nail psoriasis, the palmar plantar psoriasis, genital psoriasis, and the inverse or flexural psoriasis. And actually we use a PASI to determine the extent and severity for our psoriasis patients in most of our dermatology consults. And this stands for Psoriasis Area and Severity Index. And this combines lesion severity with body surface area affected. And this is done pretty much in all our consults with our psoriasis patients every time they're seen, as it's sort of a nice objective marker of severity for most of the psoriasis patients. And it scores redness, thickness or induration and scaling in 4 body areas like the head, upper limbs, trunk and lower limbs. And then each is weighted by body proportion and it gives it a score total out of 72. And so for PASI is 0 to 5, it's a very mild form of psoriasis. If it's 6 to 10, it's a moderate form. If it's greater than 10, it's severe. And actually, to qualify for biological treatments in Australian patients, you typically need a very severe PASI of over 15, as well as have failed 2 other therapies.
Now, there's something called, is it Koebner phenomenon and auspice signs? Are these useful? What are they?
The Koebner phenomenon is when you get psoriasis in an area of trauma, such as from scratching or friction from your clothes, in scars, post-surgery, in tattoos, in burns, including sunburns, and it's also called the isomorphic response. And so wherever you've injured, you can then develop a patch of psoriasis, typically a week or 2 after the injury, but this can vary. Sometimes it comes up a day after or weeks after. It's actually really common and it's reported in about 25 to 75% of patients. And it does seem more likely in active or unstable disease. And it is clinically useful because it does explain trauma-prone distribution and does help sort of direct counselling about friction, scratching and skin injury to try and minimise this. And the auspice sign, however, is not really very clinically useful. This is when you get pinpoint bleeding after removing the scale from the plaque. So if you gently scrape the scale off, you'll see multiple tiny bleeding points of the numerous capillaries because the psoriasis plaques have thin suprapapillary dermis and dilated tortuous capillaries in the dermal papillae. It's a classic teaching sign and in every textbook, but it's not sufficiently sensitive or specific to be useful in modern clinical practice and not clinically a very good diagnostic sign.
How common is psoriatic arthritis? So making sure I'm getting that right. I need to work on that one.
That's okay. Psoriatic arthritis is actually really common. Travis, it affects about 20 to 30% of patients with psoriasis overall. And some specialist cohorts actually report up to 40%. So this means every patient with psoriasis should be screened repeatedly for joint disease because delaying diagnosis can actually lead to structural damage and disability. So most commonly, the skin signs and symptoms precede musculoskeletal manifestations by 10 to 12 years. However, in children, the reverse is true, with 80% of paediatric cases commencing with the arthritis 2 years before the psoriasis. The psoriatic arthritis is a heterogeneous disease and it can present in several ways. And distinguishing between inflammatory and non-inflammatory arthritis is actually really challenging, but it's also critical. So the red flags are morning stiffness, with stiffness lasting greater than 30 minutes after immobility, joint pain, swollen or tender joints, dactylitis, heel pain, Achilles pain, plantar fascia pain, inflammatory back pain, and reduced function. So severe flexural and scalp psoriasis are all associated with an increased risk, but nail psoriasis in particular should heighten suspicion because nail disease is strongly associated with psoriatic arthritis. In fact, the risk of developing psoriatic arthritis is 3 times higher than those without nail disease. And nail disease in psoriatic arthritis is seen in 70 to 90% of patients. So the nail matrix disease, which is the base of the nail where it hides under the cuticle, that causes pitting, which are typically the pitted dots into the nail plate. Leukonychia, or those white spots that you see, which have nothing to do with calcium or zinc deficiency, by the way, and red spots in the lunula, which is that distal part of the nail matrix, and the crescent moon-like area that you see especially over your thumbnail. That is the nail matrix there. And any sort of form of nail matrix disease can also cause crumbling and deformity of the nail plate. Whereas the nail bed disease causes onycholysis, which is where you get detachment of the nail plate from the nail bed, especially distally. And a little bit more proximally, you might get the oil drop or salmon patch change. And you can also get thickening underneath the nail plate, which is subungual hyperkeratosis, and also little splinter hemorrhages, little bleeding of those dermal papillae. So nail disease is a high yield clinically because sometimes it's the only visible psoriasis, and it substantially increases suspicion for psoriatic arthritis. So please examine the nails in all your psoriasis patients. So the types of arthritis you'll see, the classic one is the asymmetric oligoarthritis, and this is the commonest pattern, and it's quoted at about 70% of presentations with psoriatic arthritis. So the lower limb joints, the proximal and distal interphalangeal joints are the most commonly affected. Symmetric polyarthritis occurs in more only about 15%, so in the minority. This looks almost exactly like rheumatoid arthritis, but is actually psoriatic arthritis. Distal interphalangeal joint predominant disease is particularly associated with nail psoriasis. But sometimes it's axial disease, and this is when you have spine and sacroiliac joints involved, and this causes particularly pretty awful back pain and is actually much more common in males with nail disease, and also inflammatory bowel disease is also associated with this type. Enthesitis is common, which is inflammation and tenderness where the tendon, ligament or joint capsule inserts into the bone. And this occurs in about 30% of patients. And the typical sites here again are the Achilles tendon and the plantar fascia. And the sausage digit or dactylitis is a very characteristic type of psoriatic arthritis, and it occurs in about 40% of patients. And that's where there's swelling between the finger or toe joints with decreased mobility and deformity. And this often actually occurs a lot in the toes as well as the fingers. And then rarely another form of psoriatic arthritis, which is a sort of a rare form, thankfully, but a very severely destructive form, is called arthritis mutilans, with a very sort of destructive, dystrophic, very disabling form of arthritis.
You mentioned the difference between children and adults with psoriatic arthritis. Is there any other differences between children and adults?
Yeah, I mean, there are differences. I mean, the underlying biologies sort of overlap, but the clinical pattern and practical burden and some of the associations and triggers and lifestyle factors are obviously different. So globally, the incidence in children is about 0.5 to 1%, and the peak onset is actually in later childhood, around 8 to 12 years of age, but it actually can occur at any time, including in infants. In children, normally the plaques are thinner, softer, and less scaly than in adults. Sometimes the erythema is more faint, more subtle, and actually a pale pink. And children often have more facial, scalp, and flexural involvement. And the nappy area involvement is another common site in young infants. Napkin psoriasis typically is very well demarcated with sharp edges, and it includes the folds, unlike typical nappy rash or irritant dermatitis or eczema, for which it's often misdiagnosed. The guttate psoriasis that we've mentioned before is especially common in children and adolescents, and typically post-infectious, especially streptococcal throat. And this type of psoriasis looks like a sudden eruption of raindrop-like papules, typically over the torso, and might be confused with pityriasis rosea, as it may follow the lines of cleavage like the Christmas tree pattern described in pityriasis rosea. The nail psoriasis is actually common in children, especially pitting and onycholysis, and it occurs in up to 40% of cases. Pediatric psoriasis is often mistaken for other diagnoses, especially eczema, tinea, or seborrheic dermatitis, because of those flexural and facial sites. But the psychological burden can be very high. It can affect sleep, school, sport, confidence, and family functioning. And actually, the improvement in treatment options is making significant inroads to minimising disease burden in children too, with several biological treatments now also available for paediatric patients. Does
Pregnancy affect psoriasis at all?
Yes, but not predictably for every patient. So 40 to 60% of patients actually improve during pregnancy, whereas about 20 to 30% stay the same, and only 10 to 20% will worsen. But unfortunately, many, like up to 90%, will flare postpartum. So pregnancy-related immunological and hormonal shifts probably explain why women improve during gestation. Pregnancy is thought to be a T helper 2 dominant state, with the suppression of the T helper 1 and T helper 17 pathways, and possibly why psoriasis improves but eczema worsens. So management often needs modification, especially before conception, during pregnancy and in the postpartum period. And family planning is a really critical consideration when planning systemic treatment for psoriasis, remembering that methotrexate and particularly acitretin are completely contraindicated in pregnancy, with acitretin not recommended at all during fertile years, as it really does need to be ceased 2 to 3 years before conception, whereas methotrexate needs to be ceased 3 months prior. And some topical treatments are also not considered safe, so it's important to follow the safe pregnancy drug therapeutic guidelines. But narrowband UVB, or ultraviolet light in the B spectrum, is very useful and an important treatment option and is considered safe in pregnancy. Many of the biologics also these days are considered safe to continue in early pregnancy, but are typically ceased at the end of the second trimester to minimise fetal immunosuppression and allow neonatal vaccination. And pustular psoriasis of pregnancy, or impetigo herpetiformis, is a rare but very severe obstetric dermatological emergency, which typically occurs in the 3rd trimester with fever, systemic illness, widespread generalised pustules, and hemodynamic and metabolic instability. So a significant risk to both mother and baby and requires urgent obstetric and dermatological care and admission.
I would just like to say for the record that it's so cruel that it flares postpartum. I mean, if I ever had the chance to create a species, the ones that get pregnant would just get a get-out-of-jail-free card for the rest of their lives.
Yeah, Steve, this is why I say, look, if there's a God, it is a male.
Now, you mentioned treatment for pregnant people. How effective is treatment, or how useful is treatment for patients in general?
Yeah, so Travis, treatment is now far more effective than it was a couple of decades ago, and so many amazing advances have occurred in the last 10 to 20 years, and actually continue to occur as we speak. But, it's a sort of staged, stepwise approach. So in all patients, we have to always start our treatment with general measures and minimising risks and minimising exacerbating factors and looking at the whole general health and being holistic. Vitamin D supplementation can be really useful. So can maybe fish oil and turmeric for some patients too. For minimal or limited disease, topical therapy remains the mainstay of treatment. The narrowband ultraviolet B phototherapy remains effective for more widespread thin plaque psoriasis, but it's not a long-term option. And then traditional systemic agents such as methotrexate, cyclosporin, and acitretin still have important roles in selected patients. But now there's more targeted treatments. So targeted oral therapies such as apremilast and more recently deucravacitinib, as well as biologics targeting TNF-alpha, interleukin-17 and interleukin-23 have absolutely transformed outcomes. So modern treatment goals now include meaningful symptom control, special site control, quality of life and joint screening, and not just modest plaque thinning. In fact, we're aiming for complete or almost complete resolution of disease. So for the topical treatments, topical corticosteroids do remain the first line for most limited plaque psoriasis. And we do choose the potency based on the site and thickness. So, potent or very potent for the thick plaques on the palms, soles, extensors, but lower potency for the face and sensitive areas like the flexures and the genitals. Vitamin D analogues like calcipotriol definitely help decrease the keratinocyte proliferation and are commonly used alone or in fixed combinations with the topical steroids. Keratolytics like salicylic acid can help lift the scale. Coal tar preparation, there's still some that are available commercially. They have a more limited role now, but they can be useful in selected scalp or plaque disease. Topical calcineurin inhibitors like Elidel or tacrolimus, which are kind of more off-label for psoriasis, however, are very helpful for areas where you really want to minimize steroid burden, so the face and sensitive areas. And we've sort of mentioned phototherapy. This is really helpful and it's available widely in Australia. Normally, it takes about 3 times a week and it takes about 6 weeks of attending. And typically, it's something that you can have on PBS and bulk billed on Medicare, so it shouldn't be very costly. The main issue with it can be very impractical for those that live remotely, have inflexible work schedules, or have a past history of photosensitivity or a skin cancer risk. Then we sort of discussed the typical systemic agents like methotrexate, cyclosporin, and acitretin, which still have their roles but have their pros and cons. And then the more targeted oral systemic therapies, so the Premolast, which is an oral phosphodiesterase 4 inhibitor, which is a non-immunosuppressive option but does help with inflammation. It can be really helpful for patients that want an oral treatment or when conventional immunosuppressants are unsuitable, but it has got some side effects for some. And deucravacitinib, which has just become on the PBS in the last year, is an oral selective TYK2 inhibitor, which has been approved for adults with PASIs of 12 and over, so a little bit less severe than the injectable monoclonal antibodies. But these do need to be prescribed by dermatologists for psoriasis, but then can be continued on by general practitioners once it's been started. Then the biologic therapies, which really have revolutionised the treatment, particularly of severe psoriasis, is available on PBS. These are typically now pen-like injecting devices that the patient injects themselves. But again, these do need to be prescribed by a dermatologist and need to be continually prescribed by dermatologists. Sort of the most commonly known and the oldest ones are the TNF-alpha inhibitors. So these are the most established, and these are particularly useful for patients with also arthritis, or there's a form called certolizumab, which is one that's very useful in pregnant patients because it doesn't cross the placenta. And these days, however, there's sort of newer options. The IL-23-12 combination then came after the TNF-alpha. That's called ustekinumab or Stelara. And the nice thing about this one is that you only need to inject it every 12 weeks. Then after that came the IL-17 inhibitors, secukinumab, ixekizumab, and more recently bimekizumab. These are all available on PBS. And these are very helpful for patients that have really severe psoriatic arthritis as well, and actually are often used by our rheumatology colleagues too. The main issue with these is that you need to ensure patients don't have inflammatory bowel disease, and sometimes you can get candidiasis with this monoclonal antibody. And then more recently, interleukin-23 inhibitors have come along, guselkumab, risankizumab, and tildrakizumab. These seem to have the least immunosuppressive effect and often have a rapid onset of action and very strong efficacy, with some of them having very convenient maintenance dosing, either only needing injections every 8 or 12 weeks. So these practical biologics, to select them, you sort of need to determine the patient, the efficacy of what we're trying to treat. Is it the skin? Are the joints also involved? Is there an underlying inflammatory bowel component? What sort of dosing does the patient prefer? Is there family planning happening? Have they had previous biologic exposures? Have they failed any before? what sort of infection screening needs to be done, and what their eligibility on PBS is. So as I said before, these days we are aiming to clear or almost completely clear our patients of their psoriasis.
Laura, I can fully understand why you're a senior lecturer and a supervisor of training. You have taken me, who had previously dismissed psoriasis. When Travis suggested it, I thought, isn't that just something light that sort of comes and goes away? But you've hit us with the immuno aspect. You've shown the many different aspects of it and triggers, etc. So perhaps in closing, while I sit here chastened, are there any final bits of advice you have for doctors or patients about psoriasis?
Thanks, Steve. I'm hoping you're examining your nails and your skin too.
You saw we were actually looking at our own nails as you were speaking.
I've got lovely crescent moons at the moment.
Beautiful. I'm pleased to hear that. Yeah, absolutely. I would like to just start with patients. Firstly, for patients with psoriasis, please don't think you have to put up with this, that this is only superficial or that it's not important. It's real, it's common, and it's treatable. And the skin is actually a highly visible organ and actually our interface with the world. So we should not underestimate the impact and psychological burden of disease of the skin. And I also want to emphasise that this is not contagious. It's got nothing to do with hygiene and it's not your fault. You've not caused it. Many patients that we encounter have had less than satisfactory experiences when seeking medical help for psoriasis and might have felt dismissed or made to feel that their condition is trivial. And sometimes they've been given one small tube of cream with no follow-up. So, remember, psoriasis can affect confidence, relationships, work, sleep, exercise, intimacy, mental health, regardless of the amount of skin affected. So my advice is to encourage patients to seek help, especially with doctors with an interest and expertise in the skin, and to know that there's really good, safe treatments these days. And in fact, as I've said over and over, the aim is to have clear skin. So also, please seek help if you've got joint symptoms. These are really important to mention to your doctor and should be addressed early for the best outcome. And I guess also, please try and take care of your health in general. Prioritise yourself as you are important. Sleep well, stop smoking, minimise alcohol, eat the best you can, and manage stress, as these factors absolutely decrease the severity of psoriasis, but also minimise systemic inflammation and the possible implications on your cardiac and metabolic health too. But again, to reinforce that it's not your fault that you've got psoriasis and that you can only do your best. And ideally, your doctor can assist in these measures too. And then I guess for doctors, please take this condition seriously. This is a chronic inflammatory disorder, and although for some it might appear to be very mild, for many the impact on their quality of life can be far-reaching and is often underestimated and not always associated with a high severity index and area too. So we know that this condition is significantly beyond the skin and not only affects nails and joints, but metabolic, cardiovascular and mental health. So please look beyond the skin and examine and assist your patients holistically. And, remember, certain sites might look like limited disease, but can have really severe impacts, especially the scalp, the genitals, the hands and feet, the nails and the face. And please screen for arthritis every time. This is so important. Ask about morning stiffness, swollen joints, dactylitis, heel pain, enthesitis, inflammatory back pain, and functional limitation. And look at the nails. These should heighten suspicion. So also think beyond the skin to mood, cardiometabolic risk, obesity, smoking, alcohol, and pregnancy planning where relevant, and help your patients to have as healthy a lifestyle as possible and address any habits that might be exacerbating severity. And to remember that psoriasis is a marker of broader inflammatory risk, and to, remember to address these associations. And please don't undertreat. These patients can have clearance of their skin. And please follow up your patients. If they need specialist care, please don't delay referral. And also include as much useful detail in the referral as possible so the urgency of their review can be triaged appropriately.
Aren't you relieved I'm not a GP, Laura?
I think I'm done.
Associate Professor Laura Scadamalia, thank you very much for being part of This Medical Life.
It's been my pleasure.
Dr. Grace Liu is an anatomical pathologist with Histopath in Sydney, Australia. Grace is a certified dermatopathologist with memberships in the International, American and Australasian Dermatopathology Societies. She's also actively involved in training and contributing to the Australasian College of Dermatologists Dermatology Trainee Program. And Grace is our guest today on This Medical Life podcast. Welcome.
Oh, hi. Thank you. Thank you for having me. It's an honor to be in this channel to share knowledge of pathology.
Thank you, Grace. We love having you here. How difficult is it to diagnose psoriasis on a skin biopsy?
That is a very good question. So typically when I receive a request form, if it says rash, scaly rash on the elbow, psoriasis. And the biopsy I receive is adequate and it shows classic morphology of psoriasis histologically. And then it is actually a very easy diagnosis to make. We just say, yes, psoriasis form tissue reaction pattern compatible with psoriasis. However, generally, clinicians do not biopsy classic psoriasis because you can diagnose them clinically and you don't need to biopsy them, spare them with a procedure. So what we receive is when the clinician are not sure whether this is a psoriasis or is something else. So that sometimes can make it difficult because it depends on what is the clinical setting. And also it depends on what is a differential diagnosis, whether the biopsy is adequate in the correct site, and whether it shows classic features. So a lot of these conditions, they query such as eczema, pityriasis rosea, infections such as fungal infections, they can all sort of histologically mimic psoriasis. So sometimes it can be quite difficult. So the short answer is no, it's not always easy.
What are the changes that occur in the skin of a patient with psoriasis, though?
Okay. So psoriasis is under what we call a psoriasis form tissue reaction pattern. So in non-neoplastic skins, the skin, when they are under some sort of injury or disease states, they actually manifest themselves in several ways. So that's how we categorize them. And then we have a list of differential diagnoses in each categories. So psoriasis is under the psoriasis form tissue reaction pattern. So under which there are several differential diagnoses. But the features of the psoriasis will be the regular epidermal hyperplasia, meaning the retics are elongated in an equal length, equal width, and from the top layer, when we're looking at the skin, you'll get hyperkeratosis, you get parakeratosis, you get neutrophils in the stratum corneum, you also get neutrophils in the epidermis. Then looking at the epidermis itself, you actually get the basal layer being very proliferative, become hyperplastic, and the granular layer actually diminished or absent. And the dermal changes usually characterized by there is an increase in dilated, tortuous blood vessels high up in the dermal papillae. You also get this thinning of the suprapapillary plates in the epidermis. So those are the sort of classic features of plaque psoriasis.
Do we know why it affects like areas such as the elbows, knees, scalp, or lower back? Why these areas?
So to answer that, we kind of had to come back to the pathogenesis of psoriasis. So psoriasis is a chronic immune-mediated condition. So when to make it sort of simple to understand, is when the epidermis or the keratinocytes is under some sort of insult. So it could be a physical injury, it could be some sort of medication you're taking, infections, even stress. It causes this injury to the keratinocytes, and the keratinocytes will release immune mediators or say, oh, look, need help. And they will sort of recruit the innate and the adaptive immune systems. So there's a lot of immune chemical cytokine cascade, which will attract the neutrophils, the lymphocytes, which again, release all these chemokines, all sort of chemicals, which will stimulate the keratinocyte to proliferate quicker. So instead of having a normal 28 cycle for skin, it's been shortened to 3 to 5 days. So that is why you see you get this silvery plaque, because they're proliferating so fast. And why is it on the flat surface? It's because those are the areas that are prone to get injury. So, your elbows, your ankles, you tend to knock them, and because then you have psoriasis plaque on those regions, again, you're again prone to get further injury. You might pick on them, you might knock on them, and whatever reason. So that is why the fracture aspect is a common side.
I am going to expose myself as a layperson here, but psoriasis is often itchy. If someone's been itching really viciously, does that make it harder to get a biopsy and then to interpret it further? Is it causing damage?
Yes, absolutely. So, because when it's itchy and scratching, you actually cause a secondary phenomenon, because the skin had to respond further insult, right? So it's already, suffering from this autoimmune insults from your body, but because you're scratching it and you have this external force, you get this effect of scratching. So we see the epidermis become more hyperplastic, more injury on that. You get ulceration, and when you have ulceration, it actually creates even more inflammatory response, and it can actually camouflage, obscure the underlying pathology. So it can actually become really difficult. That is why when we advise clinicians to do a biopsy, is to avoid those regions where there is ulcer, there is a severe escalation. We don't want those secondary changes to obscure the classic features of psoriasis.
Now, you mentioned some of the other differential diagnoses, such as eczema. Is there any clinical information that is useful for you to distinguish between psoriasis and other diagnoses?
Oh, yes, of course. So with skin pathology, is always a clinical pathological correlation. It's so essential. With psoriasis or any other sort of differential diagnosis included, I would like to know, is this presentation symmetrical? Whether it's certain sites being affected. Does the patient have a previous manifestation such as eczema when they were trial? Whether they have any other non-allergy, patient history, any history of psoriasis or eczema, any medications, because that will also change how the histological features. Itchy, other symptoms such as nail peelings, any onycholysis, because they are generally associated with psoriasis, and also other systemic features such as arthritis. So yes, any sort of information might help to differentiate the two conditions, because they can actually mimic each other so closely. And the other thing to note is sometimes they can actually happen together. So you can have psoriasis and you can have psoriasis with a secondary eczematous process on top. So that makes it even harder for us unless we have a full evaluation of the clinical information.
When you're taking a biopsy, is there a best location to take it from? In which case, I mean, do you take it from the middle of the lesion? Do you take it from the edge of the lesion? Or do you even like to have a biopsy which is a completely unaffected area to compare?
Yeah, okay. With psoriasis, because we want to see the classic features, so we want to see established lesions. When you biopsy them too early, you might just get spongiosis without all the established morphology, because it's too early. It's too early for the cells to actually, proliferate and show the features. So too early is usually non-diagnostic. Too late, the chronic eczematous process mimic psoriasis closely. So when they are so chronic, it also lost a lot of features of classic psoriasis. So it's not helpful. So we tend to say we want the established lesion, meaning they are, it's not too early or too late. So we want to take it at the edge of the rash. Not from the center, not from the little pinpoint lesions at the periphery. We want it to be at the edge of established silvery plaque. So obviously avoid areal ulceration, excoriation, infection site. Yes. And I think that is main. Yeah. And punch biopsy is usually the most favored biopsy procedure, because if you do a shape biopsy, we can't really see the underlying dermal changes. And obviously, too superficial, just not much things we can go with. Yeah.
When you talk about punch biopsies, I noticed that doctors' punch biopsies are getting smaller and smaller these days. Is there a recommended size that you would sort of say, 4 millimeter, kind of 5 millimeter, or the bigger the better, or?
Well, we want to be practical, obviously. Yep. We can't have, if it's like, let's say, the psoriasis involving the palm, you can't potentially get a huge biopsy, isn't it? So sometimes it's site-specific, and also what, how much you can get. Obviously, we say, yes, the more the better is always helpful, but site dependent and punch biopsy, I would say 3 to 4 millimeter is adequate.
Yep.
I think that is generally the recommendation.
Now, I know a lot of skin pathologists like immunofluorescence. Is that relevant here when you actually sort of send in a specimen that's one in formalin and one fresh? Is that useful in this case?
It's funny because sometimes we want direct immunofluorescence, we don't get them. And when we don't want them, then we get a lot of them. To clarify, direct immunofluorescence is generally used when we suspect certain conditions. So immunobullous disorder, so things like bullous pemphigus, bullous pemphigoid, and other immunobullous disorder. The other ones are the connective tissue disease, so lupus. The third one is vasculitic lesions. So when you query vasculitis. So those are the three conditions where the direct immunofluorescence is useful. So psoriasis doesn't show any pattern in direct immunofluorescence. So it's not used to diagnose psoriasis. However, I have to say, if your differential diagnosis includes those three differential, let's say you have lupus in your mind, you have, because bullous pemphigoid can be very itchy, and then in the early stage, you get a urticaria. If somehow it's in your differential diagnosis, then those direct immunofluorescence will help to rule out those conditions. But it's not it doesn't help me diagnose psoriasis, if you know what I mean. Yeah.
And then just looking at the pathogenesis of psoriasis, do we know, because it's autoimmune essentially, do we know what's actually being targeted by the immune system?
We think it's the keratinocytes. So because obviously you see it's a response of the keratinocytes. There's this hyperreactivity. There's this proliferation. So we believe that it's some sort of proteins in the keratinocytes that the body is attacking to. So it will start to proliferate. That's what we believe at the moment.
Grace, do you have any final advice for doctors about psoriasis?
I think as a dermatopathologist in general, whether it's psoriasis or not, we really want the clinical information. Okay, and very frequently we don't get that. It's kind of a very strange thing, because when a clinician writes a referral letter to other specialists, they will have a letter, asking why they're referring a patient and what their impression is. But we don't get that as pathologists. We have a request form, which seems like a formality, So I think whether it's to do with psoriasis or not, the information that a clinician provided is very important. The distribution, any other associated symptoms, medications, any sort of information is helpful. So I think that is what I would like to convey to the audience, the importance of having adequate information to us, because it is a clinical pathological diagnosis. Yeah.
A question to both of you. Are the forms that your pathology clinics giving as referral forms encouraging GPs with enough space for such information?
It's a challenge. When we actually look at the information that's given, I think it's about 60 or 70% of request forms don't have any clinical information on them. The problem is that pathology is probably a victim of its own success, that we actually often give good answers even without clinical notes sometimes.
Yes.
And then that is transferred across everything. And the problem is with skin particularly is it's so much of the presentation, it can actually completely change the actual diagnosis if they've had it for 6 months versus if they've had it for a week. This is the kind of balancing act, is that pathology is... yes, you have that tiny little box that's, a bit of a challenge. We're trying to encourage more electronic submissions with a lot more information to try and get it out. But it is, it is a challenge to try and encourage that. So that's why we have questions like this. Grace has answered it. Please give us information.
Yes, and I think sometimes even photograph is quite useful in rash, because then we can actually see them. So as a dermatopathologist, we are also trained clinically, not clinically, we also know the clinical information. So looking at the picture and looking at histo actually help us to make a sensible diagnosis. Yeah, and, we are pathologists. We are not tissue whisperer. We can't just say, come on, can you tell me what sort of process you are having, I wish I can, but, it is not.
So I think you're both saying that when you're a GP and you've got a patient with this particular condition, we don't want your contribution on the referral form to be skin deep. Thank you. I'm here all week. Dr. Grace Liu, thank you very much for joining us on This Medical Life.
Thank you so much for having me.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.